Alright, as it says here, we will be covering the urinary system. This is going to be one of our shorter lectures, so let's make the best of this extra time. Hopefully you'll have to study. Today I've got my husband's cheese head on. He's a Green Bay Packer fan. Let's see here. The image shows here the urinary system. It isn't as in-depth as the last week's digestive system, but the few parts that do make it up are quite important and yield some very common issues you will that'll hopefully help you diagnose in the lab. All right, common signs and symptoms of urinary system disease and disorders include several urinary changes. Remember that medical terminology clue for urine is urea. Use this to help decipher the disorder like nocturia, which is nocturnal, nighttime, and then urea for urination. Hematuria, heme for blood, urea for urine, so this means there's blood in the urine. Looks like my dogs are joining me. Let's see, where else? Hematuria, okay, dysuria. So this is a painful urination. Pyuria is pus in the urine, or an increase in overall urgency is also felt as a sign and symptom, and frequency. Let's see here, pain in the flank or lumbar region related to the location of the kidneys. Also fever, nausea, vomiting. Often you'll see nausea, vomiting annotated as N/V. Anorexia, malaise, fatigue, and lethargy. Cystitis and urethritis. This is seen very commonly with urinary tract infections. Cystitis would be an inflamed bladder. Urethritis would be an inflamed urethra. UTIs are the second most common type of bacterial infections seen by providers, with the first being an upper respiratory infection. Bacterial causes are E. coli being the main culprit, with Proteus, Klebsiella, Enterobacter, and Serratia species coming up close in the rear. Urethritis may also be caused by Chlamydia trachomatis or Neisseria gonorrhea. Women are 10 times more susceptible than men due to the location of the urethra opening being so close in proximity to the anus, as well as it is being very short. This shortness in length means that the bacteria do not have as far to travel before getting to other regions of the urinary tract to spread infection. Signs and symptoms yield bacteria, pain, plain and simple. I'm sure most of you can figure this one out, but it is bacteria in your urine. Also, again, dysuria, increased urinary frequency and urgency, pain above the pubic area, and cloudy, bloody, or foul-odored urine. Okay, pop quiz. UTIs are the second most common bacterial infection after what type of infection? The answer? Respiratory, specifically upper respiratory. All right, moving on to the kidney. Pyelonephritis. Pyelonephritis is an acute form, is the inflammation of the kidney and renal pelvis due to an infection. I hope since you have all done your reading that you are familiar with the kidney anatomy. As a refresher, here's a crude diagram and the inner workings. Please take the time now to locate the renal pelvis. This infection can result in the destruction or scarring of renal tissue, impairing the kidney's function. The word renal will be your medical terminology clue in the future for somehow being involved with the kidneys. This one isn't an easy one to remember, but the word renal has Latin roots, so there's no changing that. Pyelonephritis is the most common type of kidney disease, and it is usually caused by E. coli. Other less frequently causes of infection include Proteus, Pseudomonas, Staph, and Enterococcus. A physical exam may reveal tenderness during palpitations of the abdominal or lumbar areas. Urine may appear cloudy or have a fishy odor to it. A culture and sensitivity test would be performed on a midstream clean catch urine sample. A urinalysis may reveal urine casts, white blood cells, bacteria, and hematuria. This image to the right is a chart of several types of urine casts. All help point to potential issues, diseases, or disorders. A normal urine should be void of any casts. And for men, a digital rectal exam could be performed. A DRE is performed if swollen prostate gland is suspected for blocking at the neck of the bladder. Also, an ultrasound or CT scan is used to detect any urinary tract obstructions as well. Okay, this slide here is just imagery, but it'll prove helpful for the next disease. Starting from the left is the kidney. Zoom in into the nephron unit to locate the renal pyramids. It is within these units that you will see on the right the red and blue flow, red encompassing the glomerulus. That part right there is going to be involved in our next disease. So I just wanted you to get a size and area location on what we're going to be talking about. Glomerulonephritis is the inflammation of the glomeruli in a kidney's nephron. This causes the rate of blood filtration to be reduced. If filtration is lowered, water and salt is retained, affecting both kidneys now. Cause is often unknown, but if there is another infection in the body, they can be related. We have acute post-streptococcal glomerulonephritis, or APSGN, or other bacteria, viruses, parasites, may all be causative agents also. This disease comes on abruptly, and due to the salt and water retention, eyes become very puffy. Hematuria, a dark color-coded urine, is caused by red blood cells in the urine. Proteinuria yields a foamy, bubbly urine with oliguria, which is low urine output. Glomerulonephritis is diagnosed with the history, specifically to a recent strep infection, elevated creatinine, a BUN, SED rate. Urinalysis shows hematuria and proteinuria. To help get a closer, well-rounded look, an X-ray, ultrasound, CT scan, and even a renal biopsy will be completed. Now, let's on to kidney stones. These are known as renal calculi, or urolith. It is the most common cause of urinary obstruction. They are made up of concentrated mineral salts in the calyx and urinary tract. They can be like a grain of sand or very large like this bottom image. They are caused by imbalances between preventing water loss and eliminating mineral wastes. Dehydration, immobilization, excessive intake of vitamin D and calcium, gout, Cushing syndrome, UTI, and neoplasm make a patient more prone to having kidney stones. There are genetic links as well and gender biases, as this disease affects men more than women. Stones can go on asymptomatically, but eventually, more commonly, there is an intense flank and back pain. This is where your kidneys are located. The urinary urgency comes when the stone is lodged in the ureter. There'll be nausea, vomiting, fever, chills, bloody urine, and other signs of kidney stones. After a history and physical exam are taken, a urinalysis is completed to detect the elevated red blood cells and white blood cells in the urine, or to check for the presence of pus, protein, and bacteria. Blood tests may be used to confirm imbalances of minerals or the existence of other metabolic disorders. A non-contrast, highly want to stress it's a non-contrast spiral CT scan is performed. Emphasis there because if contrast is used for the CT scan, the contrast actually stresses the kidneys out a little bit more. Also, to help in the diagnosis, there would be an abdominal or KUB x-ray. To treat a renal calculi, first and foremost, the stones need to be removed, and focus should be made to prevent new stones from forming. Increased fluid intake would help that by keeping everything diluted. In some cases, the obstruction has to be surgically removed, though clearly non-surgical methods would be attempted first. A patient would more than likely have to go on antibiotics and analgesics for pain. Pop quiz! Alright, let's see here. Renal calculi are also known as, what were we just talking about? Kidney stones. I've been referring to them pretty often, so I hope you got that one. Kidney stones. Remember, renal refers to kidneys. All right, next one, hydronephrosis. So you see nephron in the word. Hydronephrosis is the distension of the renal pelvis and calyxes of the kidney due to pressure from accumulating fluid, meaning that the urine backs up into the urine backs up into the kidney from the bladder. This pressure impairs and eventually interrupts kidney function. An obstruction could be a definite cause. For adults, this disease is often acquired, resulting from blockage by neoplasms or kidney stones. For male patients, a benign or malignant enlargement of the prostate can be a causative agent as well. In women, this condition could result from complications in a pregnancy. Children usually get this by some form of congenital defect in the urinary tract if diagnosed young. Palpitations and percussions of the abdomen may reveal distension of the kidney or urinary bladder. History of changes in volume of urine output, like difficulty voiding and pain, may often be found. A BUN is used to assess kidneys' function, while a urinalysis may show hematuria, pus, and bacteria. Doing so could prove helpful in determining the extent of any impairment of renal function. Again, an ultrasound, non-contrast, spiral CT, or MRI proves helpful too. Acute tubular necrosis. This is referring to the rapid destruction or degeneration of the tubular segments of the nephron in the kidney. It is caused mostly by renal ischemia, or the interruption or impairment of blood flow, that's what that means, in or out of the kidney. This is often produced by severe trauma or as a complication of surgery or exposure to toxins, transfusion reactions, or pregnancy complications. Acute tubular necrosis is diagnosed with a history of the following: chronic and debilitating illness, trauma, surgery, history of transfusion again, or like I said before, pregnancy complications. Urinalysis reveals dilute urine, but with red blood cells and casts. An elevated BUN and creatinine or disturbances in electrolyte balances in the blood can be diagnostic in nature. The one on the left here in this image, though not to the naked eye, has microscopic hematuria. This potentially could be a dilute urine, but still has the presence of blood. Nephrotic syndrome. Nephrotic syndrome is a disease that affects the nephrons of the kidneys. It is a condition or complex of signs and symptoms of the basement membrane of the glomerulus, often characterized by proteinuria. This is where the body cannot keep up with the protein loss, also known as hemoglobinemia. Nephrotic syndrome is further characterized by hyperlipidemia, lipiduria, and generalized edema. A lot of terminologies here. Causes may conclude from a variety of disease processes. Around 70 to 75% of the cases result from some form of glomerulonephritis. It could also arise as a consequence of diabetes mellitus, SLE, neoplasms, or a reaction to drugs and toxins. From time to time, there are also idiopathic origins. All right, being involved in the urinary process, a urinalysis can be used in the diagnosis of nephrotic syndrome. It would reveal proteinuria and increased waxy, fatty, or granular casts this time. The blood test would reveal decreased protein albumin levels and increased cholesterol. A renal biopsy would be used to reach a definitive diagnosis. All right, a new disease, polycystic kidney disease. This disease is described as a developmental defect of the collecting tubules in the kidney. The tubules do not empty properly, resulting in the form where they swell to multiple grape-like fluid-filled sacs and cysts, as you can see in this image. This would ultimately impair the kidney's function. In adults, it is more common, the etiology is an autosomal dominant defect, and in infants and children, it would be autosomal recessive defect, both relating to genetics. Polycystic kidney disease can go on asymptomatically until midlife. There could be a colic or lumbar pain, blood in the urine, headaches, a urinary tract infection. This is diagnosed with a history and physical examination. It could reveal enlarged kidneys and hypertension and persistently high arterial blood pressure. A urinalysis is done to evaluate renal function and to detect any blood, and an ultrasound, CT, MRI would be done to check for any other obstructions or growths. ESRD, end-stage renal disease. This is the result of chronic renal failure, and the gradual progressive kidney deterioration causes urea creatinine to accumulate in blood to a toxic level. This disease affects all organs. Leading cause of end-stage renal disease is diabetes mellitus. But hypertension, chronic glomerulonephritis, pyelonephritis, obstructions in the urinary tract, and congenital anomalies contribute to ESRD etiology. Signs and symptoms include oliguria and azotemia, which is the elevation of nitrogen waste, electrolyte imbalances, metabolic acidosis, progressive weakness, lethargy, weight loss, most likely related to anorexia, pruritus, and mental confusion. Along with a history and physical exam, end-stage renal disease is diagnosed with blood tests revealing elevated serum creatinine, nitrogen, potassium, and decreased hemoglobin and hematocrit. End-stage renal disease is treated with dialysis, and kidney transplantation are the only treatments. So the main focus is to relieve symptoms, slow deterioration of renal function, and guard against complications. This would mean restricting the diet of certain proteins, salts, and potassium to give the kidney a bit of a break. Pop quiz. Leading cause of end-stage renal disease is what? The answer is diabetes mellitus, which gradually deteriorates the kidneys. All right, on to the next disorder. We have neurogenic or overactive bladder. This is where there is any amount of loss of impairment of bladder function. It can manifest as incontinence or feeling of a full bladder. Most frequent cause is trauma to the spinal cord that can damage the nerve supplying the bladder. It may also be due to MS, dementia, Parkinson's disease, chronic alcoholism, heavy metal poisoning, not talking about the music genre, metabolic disorders, UTIs, kidney stones, and enlarged prostates in males. Signs and symptoms include mild to severe urinary incontinence, the inability to empty the bladder completely, difficulty in stopping or starting a void or stream, and bladder spasms. It is diagnosed not only by a patient history and physical exam this time, but also a neurological evaluation. Oh man. Okay, cystourethography. That's a tough one. Basically, they're going in and taking a look at the bladder. It's a urine flow study and sphincter electromyography, along with images of the skull or spine, aid in diagnosis. Bladder cancer. This is when tumors are located in the bladder that arise from the epithelial cell membrane lining the bladder's interior. Transitional cell carcinoma is the most common type of bladder cancer in the United States. The causes are unknown, although cigarette smoke is thought to be a predominant cause. Predisposing factors include exposure to certain types of industrial chemicals or radiation. Individuals with chronic cystitis, remember this is the inflammation of the bladder, are more prone to bladder cancer. Also, a chronic parasite infection from Schistosoma hematobium can spend its entire life cycle in the human bladder and cause cancer. This is not endemic to the United States, though. Bladder cancer is diagnosed with a physical exam, urinalysis to detect for any blood or cancer cells, cytoscopy and biopsy of the suspected bladder lesions, along with bone scan, CT, MRI to help determine metastasis and also staging the cancer. All right, we're almost done, folks. Renal cell carcinoma or kidney cancer, also known as renal cell adenocarcinoma. It is the most common type of kidney cancer and usually grows as a single mass. Cause is unknown, but it comes with risk factors that include obesity, hypertension, long-term dialysis, and/or exposure to chemical and irritants. Here's a great image that describes how renal cell carcinoma is staged. Signs and symptoms include hematuria, flank pain that does not go away, lump or mass in the abdomen, weight loss and fever. If you notice, these symptoms are very similar to many urinary tract diseases and disorders, so diagnosing others could be done to rule out cancer. For kidney cancer, along with a physical exam, it is diagnosed with a BUN, creatinine, test being drawn, CT or IVP, let's see here, ultrasound and biopsy of any tumors. Okay, well that's it for our diseases. Here's a tip for exam 3, as it says it's what's coming up next. Along with using the objectives, of course, as a study guide, making a table up like this one that I have listed here could help you visualize and separate some diseases, and also maybe see some links and patterns in a few as well. We have gone over several symptoms, so if it helps, please use it. This exam will cover chapters 11 and 15 and will be taken by Friday, no later than 1700. Next week is a holiday, so there has been a grace period added to your quiz. Due dates, however. Discussion, sorry, I got flying right here. However, discussion assignments still stand, as it is lectures and readings as well. Try to make the best of your time off. Finals are fast approaching, so let's reach out with any questions or concerns if you have with me. Even though it is a holiday week, I will still be at your beck and call, so reach out if you need me. Have a good one, and I will see you guys later.